Hi, everyone, and welcome to the Governor's Institute's Addiction Medicine Podcast. I'm Dr. David Ryan, a clinical assistant professor with the East Carolina University Department of Psychiatry and Behavioral Medicine and the Department of OBGYN. I'm a board-certified physician in both OBGYN and addiction medicine. Today's episode is part 2 of a talk I gave for the North Carolina Academy of Family Physicians Alcohol Use Training Webinar. When is alcohol a problem and what can be done? In this part, we'll focus on treatment, covering FDA-approved medications, behavioral interventions, and support systems that can help patients move towards recovery. Glad to have you listening. Let's get into it.
Okay, and welcome to part 2, where we're going to talk about various options for treatment. So the first category of things we're going to talk about are pharmacologic treatments. There's a couple things I want you to keep in mind when we're discussing these options. First of all is that the majority of these medications were approved with the DSM-4 criteria to diagnose a use disorder. Now there's a little bit of overlap, there's a little bit of difference, but again, just keep in mind, so some of the medications that are used or the different categories that they were used to treat doesn't exactly carry over to our mild, moderate, or severe categories. But when we do look at these and we try to draw a corollary to them, we find that these medications are generally effective, very effective in the moderate to the severe categories for alcohol use disorder. None of these medications were studied with individuals with mild alcohol use disorder. That does not mean that we cannot use these medications for individuals with mild alcohol use disorder, but that they weren't studied or necessarily approved for mild alcohol use disorder. And oftentimes they're used in conjunction with different psychosocial interventions. And whether that's 12-step groups, whether that's one-on-one counseling, usually medications and one of these forms or another are going to be used together. However, it should not be required. There's a general philosophy regarding treatment of addictions and also an alcohol use disorder that while it has been shown that these other options are very effective in treating alcohol use disorder or supporting individuals, because oftentimes it's not only the physical aspects of the disease, but also the psychosocial aspects of the disease, different managements for craving, what to do in relationships, how to repair those relationships. All of these things are important, but we do not want to require individuals to do counseling or to do therapy in order to get access to medications. Because when we do that, we find that instead of encouraging individuals to engage in counseling or therapy, unfortunately what it does is just prevent individuals from accessing medication. So again, we encourage individuals to use these things. I want to present several options, which a lot of patients can find useful. But again, we do not make counseling or attendance of peer support groups a requirement for medications. So again, there's a lot of different options when it comes to psychosocial interventions. We are going to spend some time talking about Alcoholics Anonymous, which is very well known, and also Smart Recovery, which is less well known, but also very effective. Other methods that we will not necessarily cover in depth, but for you to be aware of, getting individuals with one-on-one counseling, whether that's with therapy, social work, substance use counselors, or psychiatrists. There are structured group therapies. There's also family therapy. There's 12-step facilitation, which is a formalized workbook application of the 12-step program, and then motivational interviewing, which it can be done in any setting, including in a physician or a primary care office physician or a primary care setting. When we're talking about treatment, it's very important to figure out or ascertain what the goal of treatment is. I do remember in my fellowship many times my attending asking me, well, what does the patient want? Well, what's the patient's goal? And I legitimately didn't know because I never thought to ask because I just assumed that abstinence was clearly the goal, and that's not necessarily a safe assumption. So knowing where a patient wants to go can be critically important for understanding how it is that we're going to get there. You know, if I'm planning a trip and my wife thinks we're going to Asheville and I think that we're going to Kitty Hawk, we're going to have a very different approach about how it is that we're supposed to get there. So understanding what the destination is going to inform not only the provider but also the patient on how it is or the options that are available in order to get to that destination. And at least anecdotally, I have found that more patients with alcohol use disorders typically want to attain what I would call non-abstinent recovery. It means they're not ready to engage in abstinence, they're not ready to kind of give up alcohol totally, but they do want to reduce their risk, they do want to lower their consumption, they do want to improve their outcomes. And usually with other substance use disorders, when individuals are attempting to recover from them, usually they're looking for abstinence, but that's not necessarily a safe assumption with alcohol. So establishing a goal can be really important. It's also really helpful because how do we know we're making progress, right? If a patient's goal is abstinence, well, continued use or continuing returning to use can necessarily indicate a treatment failure. But if the goal is reduction, well, if an individual is continuing to use, but they're using less, well, then you've achieved what it is that you're looking to achieve. If the goal is reduction, it can be really important to have a number or a very specific goal set in mind, because oftentimes if you ask patients, they'll just say less. So using those NIAAA criteria, or there's the 5 and 4, or the 8 and 15 levels that we talked about in the first part of our talk, getting to those levels or below those levels can oftentimes help individuals figure out a goal or something to shoot for. And also, if you have a patient, and sometimes it can turn into a conversation, sometimes it can turn into a back and forth, and it's always really helpful for me, I have found, when I'm having a conversation with a patient and maybe their use isn't quite what we had talked about last time, or maybe it's increased, and if it ever feels like an argument, that's always a time for me to call a timeout and say, well, hold on, stop. Let me just understand what it is your goal is. If your goal is to stop, well then great, let's kind of work on that goal. But if that's not your goal, then we need to come up with a different plan. So it's always, at the very least, very helpful to have this understanding in mind, because if things start to feel like a conflict, or things start to feel like an argument, or there just seems to be a lack of clarity, coming back to that goal can be a really good way for both you and the patient to kind of recenter, kind of just touch base again, kind of do a reset, and then figure out the best way to move forward. So some other things to consider when we're starting treatment. Typically, I'll see individuals weekly, especially when I'm first starting in a treatment, just because it's a new medication, new side effects. They're trying to make some big changes. It can be really useful to have that opportunity to touch base with them once a week, at least in the beginning, to see how things are going, to sort of not only ascertain if the medicine's been effective or not, if we need to increase the dose, but also, are there side effects? Is it not tolerable? Do we need to change treatment courses for whatever reason? Oftentimes waiting a month or 2 months is entirely too much time and lets too much kind of go by without being able to intervene. Keep in mind that benzodiazepine use or other substances are commonly used, and there's an overlap between alcohol use disorder and benzodiazepine use disorder. About 1 in 5 patients in one study that were admitted for alcohol treatment reporting misusing benzodiazepines within the previous year. So there's an elevated risk for that, so you want to be aware of that. Urine toxicology testing, and the specifics are outside of the scope of this talk. However, an important thing to keep in mind is that when I use urine toxicology testing, I'm never using it as a punitive measure, meaning I'm not going to not prescribe something, or I'm going to cut somebody out of treatment because I find something on their toxicology screen. I use it like a CBC, I use it like a CMP, I use it as a point of care, or a value to ascertain how the treatment is going, to see if things maybe aren't going the way that we had initially planned, but also to identify risks so I can have an informed conversation with my patients. So once that adequate response is reached, whether that's a reduction of use or abstinence, how long does treatment typically continue? Well, we recommend that if individuals are in a psychosocial treatment, that it should continue for at least 6 months, ideally for 12. Now, if individuals are attending a fellowship like Alcoholics Anonymous, potentially that's a lifetime organization that one will join, but whatever it is that they're doing, we want them to continue to do that. Medications usually continue also for about a year as well. Studies have shown that if medication is continued for at least 12 months, the return to use rates are lower. And again, we're tailoring treatment to an individual's desires, to their stability, to their preferences, their needs, whether they live far away or how often they can come or what their desires are. I'm always trying to figure out, trying to walk that line between meeting patients where they're at, not making it overbearing or cumbersome to come to my clinic, but also doing the appropriate level of clinical supervision or oversight, right, to make sure that I'm caring for my patient in a way that's appropriate. As far as relapse or return to use rates, studies will basically tell you it's very hard to get really hard data on this, but essentially kind of common sense. The longer somebody is in remission or the longer somebody is abstinent, the more likely it's going to continue. So in different studies, they use 1 year, 3 years, 5+ years as milestones, meaning somebody with a year is more likely to have a return to use than somebody with 3 than somebody with 5, right? So the longer somebody can have consecutive abstinence, the more likely that it's going to continue. But it's a conversation, right? It's a constant conversation, and the clinician-patient relationship really doesn't end. Just with patients with diabetes or hypertension or asthma, you're seeing them in a chronic medicine model and kind of a lifetime model. It's the same thing with addiction, right? We need to make sure that we're offering the appropriate amount of oversight, the appropriate amount of clinical care, without being a barrier to care. And we're going to transition our talk right now to talking about medications, and unfortunately, one of the most disappointing statistics regarding medications for alcohol use disorder is that they are dramatically underutilized. One study showed that only 2% of patients with alcohol use disorder received pharmacotherapy. When patients were admitted to the hospital, one study showed only 1% of individuals or patients who were admitted for alcohol use disorder or complications for alcohol use were offered medication on discharge or even within the first month after discharge. And when we know these medications are really effective, when prescriptions for medication for alcohol use disorder was received, 42% lower risk of all-cause mortality or hospital readmission within the next month. So it's very, very encouraging. Those are very good numbers, but unfortunately about 1 in 50 patients actually filled a prescription on discharge. So you can see where there's a very, very big gap between the effectiveness or the efficacy of these medications and the utilization of these medications. And one of the primary goals of this talk is to hopefully get you a lot more comfortable with the idea of these medications, with knowledge of these medications, so you feel empowered or educated to start these medications in your outpatient setting. So let's go over several of the 3 FDA-approved medications at this point. We're going to start with the first one being disulfiram or antabuse. And this is a medication that inhibits the breakdown of acetaldehyde by inhibiting acetaldehyde dehydrogenase and leads to an increase of acetaldehyde in the blood. Now, acetaldehyde is related to formaldehyde, so it's an incredibly noxious substance. When individuals ingest alcohol, ethanol, it's very quickly metabolized to acetaldehyde and then very quickly metabolized to acetate, which is very benign. But acetaldehyde is not. And so the way disulfiram works is it inhibits that enzyme and it causes a disulfiram-like reaction, which is something that I would say almost all of my patients have at least heard about or are familiar with. They ingest alcohol, it leads to the acetaldehyde in the blood, which causes dizziness, flushing, hypotension, fatigue, severe chest pain, severe nausea, vomiting, a throbbing headache, basically a severe hangover that comes on like a thunderclap all at once. And it can be a very, very severe reaction. And the idea behind that is that an individual has ingested disulfiram, and because of the awfulness of this reaction, they're going to stay away from ethanol. An important aspect of the disulfiram-like reaction, though, is to understand that it can be very, very severe, and it can actually lead to severe complications, if not death. I mean, there are absolute reports of cardiovascular collapse, seizure, congestive heart failure, and death, especially for patients that are medically fragile. So you have to keep that in mind, or when I consent my patients for disulfiram, I consent them that if they were to ingest alcohol, part of the informed consent process is informing them that they could die from this reaction. It is absolutely for patients that desire full abstinence, because any amount of alcohol is going to cause this reaction. It does not decrease cravings for alcohol use. That's not the way this medication is designed or was tested to cause. And you need about 2 days of abstinence before starting this medication. And because it's an irreversible inhibition of these enzymes, the effect can last anywhere between 2 weeks. The side effects are listed there. Most are pretty benign. Very rarely do individuals end up with complications like hepatitis or optic neuritis. Most of the time it's a headache or a little bit of a bad taste in the mouth. It's also important to understand that psychosis is a very rare complication, but also something that can happen because it inhibits the breakdown of norepinephrine, which leads to an increase in dopamine. And so if an individual has a history of psychosis, this would not be an appropriate medication. So the million-dollar question, does it work? The short answer is maybe. When you dive into the studies, it was approved in like 1949, and you can understand that the FDA process for approving medications at the time weren't exactly very rigorous. There's been a modest benefit that's seen in placebo-controlled studies since then, but there are some indications, or there are some instances where this medication has been shown to be effective. And it's very interesting. If you look at to do a double-blinded trial removes sort of the really therapeutic aspect of disulfiram, meaning that if patients are told that they don't know if they're on a sugar pill or if they don't know they're taking disulfiram, well, the knowledge of what disulfiram will do isn't there, which is a primary driver of abstinence. If you look at trials where they didn't blind it, where people knew they were taking a sugar pill or they knew they were taking the disulfiram, abstinence rates in the disulfiram group were actually a lot higher. So to say that all of the studies show that it doesn't work isn't accurate. There are certain instances where it is. So oftentimes if it is supervised, doesn't necessarily mean by a parole officer, but if somebody in a relationship, like a friend or a spouse or a significant other, is part of the process of that individual taking the disulfiram, that is shown to be very therapeutically beneficial, especially when there are support people around. If the individual is engaged in counseling or they're engaged in a professional oversight organization like the Physician's Health Program or something for airline pilots, oftentimes disulfiram can also be very, very beneficial. So it's a medication that can work. It has fallen out of favor or isn't used as commonly because of the reasons that I just described, but it is a medication that can be effective. So the next medication that we're going to talk about is the one that's more commonly used, is naltrexone. It was approved for the treatment of alcohol use disorder in '94, and it is a cousin of naloxone, meaning it is a full opioid antagonist. And it might sound strange that I'm talking about opioid antagonism in a talk regarding alcohol use disorder treatment, but the assumption of the underlying mechanism is that when alcohol is ingested, because it's inhibitory and inhibits inhibitory neurons, which is my least favorite neurological mechanism, but essentially it leads to not only an increase in dopamine, because it inhibits the inhibition of dopamine, like we talked about in the nucleus accumbens, but it also inhibits the inhibition of endogenous opioids. And that's part of the euphoric or the feel-good feeling of alcohol, right, as it releases endogenous opioids. Well, what naltrexone does is it blocks the positive reinforcement of alcohol, meaning doing something to get something good or something positive. So individuals take the naltrexone, it blunts the effect of the endogenous opioid release, so that feel-good feeling isn't there anymore. So people will tell you that alcohol has sort of quote-unquote lost its taste. The drive to use alcohol is no longer there. Or when alcohol is used, less alcohol is used because it's less reinforcing, because it doesn't give you the effect that it normally did without it present. It is metabolized in the liver, but it is okay in Child-Pugh class A or B cirrhosis. We just have to make sure that we're being very diligent about following the LFTs. There is some recent information that probably shows that naltrexone is probably appropriate for patients even with advanced liver disease. But if you had a patient like that, you might want to consider other alternative medications or reaching out to an addiction medicine specialist if it's a little outside your comfort zone. But certainly in A and B class, it is certainly okay. It doesn't require abstinence as a goal, which makes it ideal for a larger proportion of the population. In fact, it was actually done in studies with patients who had not achieved abstinence. And there were many trials that have showed that it's been effective. It not only decreases the amount of alcohol that is used when alcohol is ingested, but it also decreases the amount of days that individuals use. So they use alcohol less often, and when they use alcohol, they use less. And it's been validated in many follow-up studies. We definitely want to make sure that we're checking our LFTs. We consider anywhere between 3 and 5 times the upper limit of normal okay. Again, if you're above that, you might want to talk to an addiction medicine provider or reach out for questions. However, there are some recent studies that again have shown that even with very high elevated LFTs, that naltrexone is probably safe. Again, one of the underlying philosophies behind that is what's worse for the liver, naltrexone or continued ethanol use, and the latter is certainly more dangerous and more harmful. In addition, when the studies that were done that showed the elevation in LFTs were actually done when they were using 300 milligrams of naltrexone, which is anywhere between 3 and 6 times higher what we use typically in normal therapeutic dosing. It cannot be used with concurrent opioids. So if an individual is on Suboxone or methadone or on oxycodone or other opioids for chronic pain or for opioid use disorder, this medication cannot be used because it will block the opioid and cause withdrawal. You also have to have a discussion about what happens if an individual needs pain. So if they're on naltrexone and they get hit by a car or their appendix pops, they need to know that they need to tell their doctor or their surgeon that they're on naltrexone, because yes, the opioid blockade can be overcome. Patients can get pain relief, but they need to use a lot more, and it has to be high potency, high affinity opioids like Dilaudid and fentanyl. So individuals have got to be counseled for if they need acute pain relief, that it can be achieved, but that their physicians, the patient needs to know to tell the physician that they're on these medications. When we use it in pregnancy, or if there's a surgery coming up, we would stop it probably about at least 2, if not 4 weeks before the surgery to make sure that it's out of the system so pain relief can be achieved. And then there's this idea of targeted dosing, or the Sinclair method, where patients who not necessarily want to take a medication every day, or it's not necessarily alcohol use every day, but let's say it's just Friday nights when they go out with friends, or Saturday evenings, they have found that you can take the naltrexone 1 or 2 hours before going out, and that individuals will end up using less alcohol. So it's not common that we use targeted dosing, but it's been shown to be efficacious in certain patient populations. Naltrexone is available PO or daily for 25 to 50 milligrams a day as a pill, also as an injection, as an IM injection under the brand name Vivitrol. The side effects are essentially the same. With the oral dose, you're going to have a little bit more nausea with that, which usually goes away after about a week of treatment. However, you can see the differential in cost at the bottom, which is especially pertinent if our patients don't have insurance. There have never been any head-to-head studies between PO and IM naltrexone. They're always between PO and placebo, or IM and placebo. Both are very, very effective. Some patients like the idea of taking a medication every day. Others prefer the convenience of once-a-month dosing. Either one is certainly fine and appropriate. Just if you're going to use Vivitrol on a patient, you want to make sure that they've taken the PO medication for at least a week before they get the IM injection, to make sure that there are no complications. The last FDA-approved medication that we're going to discuss is acamprosate, known by the brand name of Campril. It's a very interesting molecule. It looks like GABA and taurine had a baby, and that's what it is. It's an amino acid derivative that's excreted by the kidney. And this is my favorite, is that they don't really know why it works. We think it's an NMDA antagonist and also a positive allosteric modulator of GABA. So it sort of kind of works in a little bit of the way that ethanol does. But again, we don't really know. But it's great for patients who have advanced liver disease because that's not metabolized. They just have to make sure that their renal function is okay. And it's because it's a medication that's excreted by the kidneys. It does work. It increases the amount of people who abstain and also the number of days that individuals go without using alcohol. In head-to-head comparisons with naltrexone, it's shown to be effective. And there's some really good data out of Europe that have shown that individuals who have undergone withdrawal, meaning they're abstinent when they start this medication, that the abstinence rates at 6 months are significantly higher in the acamprosate group than the placebo group. It is 3 times a day dosing, 2 pills 3 times a day. 666 milligrams, which is a very interesting dosing number, but that's what they chose. As long as the GFR is above 50, if it's 30 to 50, you can decrease that to 330 milligrams 3 times a day, so 1 pill 3 times a day. But if the GFR is less than 30, it cannot be used because it needs to be excreted by the kidney. A little bit of GI upset, a little bit of nausea, and that's all transient. Some itching also is transient. And it removes the negative reinforcement, meaning the doing something to get rid of something bad. So the way I describe it to patients is that oftentimes individuals that use alcohol chronically get this skin crawly, like ick feeling. And the acamprosate either lowers that feeling or gets rid of it, so the drive to use alcohol is no longer there. So it removes the negative reinforcement of alcohol, the doing something to get rid of something bad. It can remove that ick feeling that patients have or dampen it, so then the drive to use alcohol to fix that feeling is no longer present. And when we look at the efficacy of these medications, it's one of the pivotal or landmark studies was a combined study that was done in 2006. And I'll go over this very, very briefly. They looked at about 1,400 individuals who are alcohol abstinent who were in treatment, and they followed them for about a year after treatment. It's a little bit complicated, but essentially, I'm going to describe it like this. Everybody got 2 pills, okay? Everybody got 2 pills, and they could either got 2 sugar pills, they got naltrexone and a sugar pill, they got acamprosate or a sugar pill, or they got naltrexone and acamprosate. And everybody got 180 minutes of counseling. Now, but there was a separate 4 groups, same 2 sugar pills, that got an additional 1,000 minutes. So everybody got 2 pills. 4 of those combinations only got 180 minutes. The 4 on the right got an additional 1,000 minutes of counseling. And then they threw in this counseling-only group that got no sugar pills on the bottom there. And they looked at everybody's outcomes. And they found some interesting occurrences. So first, everybody got a little bit better. That's the good news. Everybody got a little bit better. The groups that did the best were the naltrexone with a little bit of counseling, or the 2 sugar pills with all the counseling. There was also no additional benefit to adding a camprosate. So I think this is one of the reasons why people say that a camprosate doesn't really work, or it's kind of a misrepresentation of the combined study that using naltrexone and a camprosate didn't necessarily improve outcomes, which is why we don't necessarily use these medications in combination. What's very interesting to me is that the poorest group are the ones that got all the counseling, the extra counseling, but no sugar pills. So literally the only difference between the group with the poorest outcomes, or the least amount of improvement, and the group with the best outcomes, or the most improvement, were 2 sugar pills. So again, it just kind of shows you the effect of what taking a medication, even if it's just a sugar pill, can do, but also the way that counseling can, or maybe isn't necessarily, it can be very, very effective, but it's not necessarily the only thing that is important. So again, all of these medications showed some improvement, and all of these groups did. And when you look at numbers needed to treat, they're actually pretty encouraging for naltrexone and camprosate. And this is return to any alcohol use. This is an abstinence, right? Over to the right there, you see some numbers needed to treat for just some basic medications that we use daily, right, in primary care, or certainly the magnesium and in obstetrics. And we anywhere between 8 and 20 is our number needed to treat for camprosate and naltrexone to prevent any return to alcohol. So again, these are very encouraging numbers needed to treat, and they're very good outcomes. Let's talk a little bit about off-label medications. Baclofen is used often. Specialists in hepatology use this often. There's some good data out of Europe. They use it pretty frequently over there. It's a GABA B receptor agonist. Varying doses have been studied, 5 TID, 10 TID. It reports some decrease in motivation to use alcohol use, and some studies have shown that it can be helpful. Gabapentin, anywhere between 300 TID to up to 600 TID, has been shown in some studies, especially when combined with naltrexone, to augment the effect of naltrexone, leading to longer days of abstinence and less alcohol use when using. So it's something that we can use not only to treat withdrawal in the outpatient setting, which is outside of the scope of this talk, but to also use it to treat alcohol use disorder. Topiramate is a medication that has very good effects when it's able to be used. You start off by 25 milligrams a day for a week, and you have to increase it very, very slowly to the goal of about 100 to 150 twice a day. It's an effective medication, but the problem with topiramate or Topamax is the side effects. It has a twice likelihood of patients self-discontinuing it compared to other medications because of the side effect, most notably the cognitive slowing or the feeling sluggish, quote unquote dopamax. It's kind of a term for Topamax just because of the way it can make some people feel. And as I said, it's very likely to be discontinued, which is why in recent meta-analyses it's not shown to be as effective. And then GLP-1 agonists. This is actually, they're going to turn out to be the cure-all for everything. I mean, the evidence is not overwhelming. There's some animal studies that show that it is effective. One study over there from November showed about 7,500 participants. Almost half of them reported a decrease in alcohol use. Then one study there in February where it was actually a placebo. It wasn't just a report. It was a GLP-1 agonist versus placebo. Did show some decreased alcohol use, decreased craving, and also less cigarette use. Again, I think over the next several years, we're going to see bigger studies with more patients, more randomized controlled trials come out. And so we certainly don't use these medications as a primary medication for the primary goal of reduced alcohol use, but it does turn out to be a good side effect from it, or a good, if you have another reason to start one of these, you might find that patients with alcohol use disorder do really well. Very briefly, I'm going to talk about some recent meta-analyses. This most recent one is from 2,800 patients, 156 trials over 5 decades, looking at all the medications that we use, and they looked at all sorts of things, things that we definitely don't use for alcohol use only, like Abilify or carbamazine, also Luvox, the antidepressant. And what they found is the things that we've been using, the things that are FDA approved, are generally the ones that are most well tolerated. As I said, baclofen in there was showed in that meta-analysis to be effective, to have the most evidence for them. Again, and topiramate had the most dropouts, which again, it's an effective medication if the patient can continue on it and can tolerate the side effects. There was also a head-to-head comparison here between naltrexone and camprosate, looking at alcohol consumption in side effects at 12 weeks. And based on what we understand the mechanisms to be, this did make sense that if individuals were abstinent and they were on a camprosate or oral naltrexone, they found that any alcohol consumption was less. However, when alcohol would continue or people would return to use, the naltrexone prevented the progression more likely than to the heavy alcohol use, where the acamprosate didn't really necessarily affect that again, which makes sense in understanding their mechanism of action. If acamprosate kind of treats the negative state, right, once alcohol is then ingested, there's nothing there that's present to stop it because the alcohol is already in the system, where oral naltrexone blocks the endogenous opioid effect. So once alcohol is ingested, the reinforcement to continue using isn't there. So there's nothing surprising about this data, but again, still pretty good numbers needed to treat. So when we're looking at our FDA-approved medications, naltrexone is one of our first-line medications. We certainly use it with co-occurring opioid use disorder as Vivitrol. It's great for individuals that don't have a goal as abstinence, and targeted dosing use works very well for certain patient populations. Acamprosate is great, especially if there's heavy hepatic disease, or if individuals are on methadone or buprenorphine, let's say for opioid use disorder, and also have alcohol use disorder. Acamprosate can be very effective, or if they're on medications or opioids for pain. And then disulfiram. Patients with a strong social support, patients who can have supervised dosing, and also the studies say highly motivated, which I kind of take a little bit of issue with, because it kind of second guesses or states that if patients aren't successful, maybe they're not as motivated. Highly supervised or professional individuals, airline pilots, physicians who are in monitoring programs, I think these are more commonly used, so they're more commonly studied, but they've shown that they're effective in that patient population. When we're talking about off-label use, baclofen does have some studies that show some increased abstinence rates, but again, it does not prevent withdrawal seizures because it's a GABA B and not a GABA A, so you don't want to use it for that. Gabapentin doesn't necessarily prevent the progression to heavy use, but it does improve abstinence, again, also when used with naltrexone. Topiramate, it's effective. It's not more effective than naltrexone and acamprosate, and we have to keep that high dropout rate in mind due to the side effects. And then again, GL1P agonists. We'll see what the data shows as it continues to come out. Some other interesting findings, varenicline or Chantix, when it's prescribed to individuals who are smoking, they will start using alcohol less frequently, which is interesting. Prazosin, especially if there's comorbid PTSD, can also be effective there. And interestingly enough, ondansetron or Zofran, when studied in male patients under the age of 25 with a family history of alcohol use disorder, this medication is particularly effective. Why that is, I have no idea. I've never prescribed Zofran to treat alcohol use disorder, but it is interesting that some studies will show decreased alcohol ingestion when in this specific patient population. All right, we're going to spend the last several minutes talking about peer support networks or mutual help networks, and it can be a critical aspect and huge support for individuals in recovery, but one I have found is not necessarily, people or providers know about them, but they don't know a lot about them, so I think it would be helpful to give a little bit more in-depth discussion, get a little bit more background from these organizations so you have a better idea of what maybe you're referring patients to. The most common one, or the one that is most depicted in television and movies, either accurately or inaccurately, is Alcoholics Anonymous. And it was founded in June 10th, 1935, and it is essentially a mutual help group by individuals who identify themselves as alcoholics. We don't use the term alcoholic in addiction medicine. It can be stigmatizing. We don't label individuals as alcoholics or addicts. We use alcohol use disorder or patient with alcohol use disorder. But in this group, people self-identify as alcoholics, and it's a way of them owning their own disease process. And it's very interesting. It was actually founded by these two individuals here, Bill Wilson, who was a stockbroker in the late 20s, and Dr. Bob Smith, who is I believe, a colorectal surgeon as well, who had an alcohol use disorder. And Bill Wilson ended up getting with a religious group called the Oxford Movement, and he ended up finding sobriety or finding abstinence from alcohol. And he was running around, trying to spread this, religious, awakening that he had, not from a religious angle, but trying to get individuals into this group called the Oxford Movement, and he wasn't having a lot of success with it. But he found by trying to get other people into recovery, by trying to help other individuals with alcohol use disorder recover, he found that he himself was actually staying sober himself. And then he ended up meeting Dr. Smith through some very interesting serendipitous, if not providential circumstances. And Dr. Bob Smith found sobriety as well. He actually was abstinent, and AA's founding date is the day of Dr. Bob Smith's last drink, which was June 10th, 1935. And one of the tenets is, again, what they found was by trying to spread the word or help other individuals recover from alcohol use disorder or alcoholism, they themselves were able to stay sober. And that's one of the primary tenets of AA, is giving this away. This is the preamble of Alcoholics Anonymous. It's read oftentimes at the beginning of meetings, and it's a summarized statement regarding what AA is and what it isn't, and I do want to share a couple important points with it. First of all is that these are not classes or lectures that individuals attend. This is sharing of experience by peers, not professionals, and that was one of the things that drew Dr. Bob Smith to Bill Wilson, was the fact that he wasn't speaking down to him, he wasn't talking to him as from a theoretical angle, that he was somebody with lived experience who knew what he was going through himself. And through that sharing of mutual experience and empathy, he was able to trust Bill, and they were able to kind of build that connection. There's really only one requirement to quote unquote join, is just the not want to drink. Is the desire to stop drinking. It is an abstinence movement, meaning that the abstinence is the goal, and what will be predicated as the goal. There's no monetary commitment, there's no money that needs to be given, and it's known as a religious organization, but there really is no specific religion or ideology. One of the tenets, or one of the primary reasons that got Bill Wilson into sobriety or into this Oxford movement, is by somebody telling him that he could choose a God of his own understanding. He did not need to believe in the Judeo-Christian, form of God or whatever it was that was taught to him, is that he could choose whatever higher power that he wanted to choose. And there are atheists in Alcoholics Anonymous, there are agnostics in Alcoholics Anonymous, and all of them have found recovery based on this finding of this idea. The program itself is based on the 12 steps, which I think, again, people have at least heard of. And what happens is an individual comes into Alcoholics Anonymous, they typically find a sponsor, and that sponsor is then tasked with taking that individual through the 12 steps. It can take anywhere between 3 months, 6 months to several years to work through all these steps. But again, some of those tenets are turning it over to this higher power, taking an inventory of the things about an individual, the things that they've maybe have done wrong in their life, or people that they have harmed, making amends with those individuals, trying to repair the damage that was done, and then just seeking to live a spiritual life. And these tenets are what form the 12 steps and form the program of recovery. AA has a pretty broad worldwide footprint, and they also have an organization based out of New York, a worldwide organization. And you can go to AA.org and you can actually learn more about that. They have, you're a member, you're a professional, and if you seek out the inside AA and you look, they have a whole part of the organization called Cooperation with the Professional Community. That's what CPC is. So if you're a provider and you're like, I just want to learn more about AA, I want to learn how I can provide resources, I want to know where the local meetings are, I just have questions I want to be answered, you can contact AA at the CPC desk, and somebody will call you back. They will email you back. They'll provide you with resources. Like, their entire job is to work with the professional community about getting AA out there and getting information out there. And they're incredibly useful and helpful. SMART recovery is also something that I learned about actually during my addiction medicine fellowship. So the SMART stands for self-management and recovery training. It was started in the mid-90s as I'm going to say non-religious or spiritual program for individuals who had alcohol use disorder, who were sort of kind of turned away either by bad experiences with religion or just didn't really feel like AA was necessarily a fit. But it offers the same kind of pragmatic program or, things to do. They teach these 4 pillars, these build and maintaining motivation, how to cope with urges and cravings, managing thoughts, feelings, and behaviors, and just how to live a balanced life. So it's kind of a 12-step-esque program, right? But it, essentially boiled down to 4 different pillars. It is not just for alcohol, and there is no abstinence requirement there. It is also not professionally run, meaning that the individual who runs these meetings is somebody with lived experience. And yes, they're tasked with leading these meetings, and yes, they're put in charge of that, but there's no monetary compensation or professional class that exists. Oftentimes meetings can be in person. They're not as widely available as Alcoholics Anonymous is, but basically in every community they have in-person meetings, and they also have online meetings as well. So this is I found my patients are really interested in this. Again, if they were sort of kind of turned off by AA, or if they're wary of that spiritual approach to it, even if, after I explain that it's not necessarily a God-centered program, they still want to avoid it. This can be something where individuals can find that peer support, can find people with mutual lived experiences that can offer them a program or steps or things to do and ways to manage different complications or urges that occur as a result of their alcohol use disorder and find very meaningful recovery. Women for Sobriety is an organization specifically for women. It focuses on an individual path to recovery. They are also abstinence-based, but also self-help. Peer-run, peer-led. They base their recovery on 13 statements of acceptance. It's abstinence-based, but it is not required to be abstinent. I will say that unfortunately in North Carolina there are no in-person meetings, but there are some online meetings again. So especially for women who are sometimes have more of a history of trauma, and again are maybe put off by what the other programs have to offer, this is a very reasonable and supportive alternative. And finally, on the opposite end of the spectrum, we have kind of the secular movement. Celebrate Recovery is, I would say, a very religious movement. It was founded out of a church in 1991. They will tell you that it is Christ-centered ministry, so it is a very Christian-based organization. I went on their website. I tried to find as much information as I could. They don't have a lot available there, but I could understand that they have weekly meetings. There is an official curriculum that they work, and they're based on workbook and they're based on scriptures. I've asked several of my patients who have found recovery there, and also several friends who have been part of Celebrate Recovery. Typically, it's not just for alcohol. It can be for any substance or even any addictive behavior, whether that's sex addiction, gambling addiction, pornography addiction. Anybody is welcome at these meetings. They usually break out into smaller groups based on maybe substance or behavior, but it's the same workbook, it's the same kind of curriculum for everything. And again, if individuals aren't scared away from a religious solution, or they're somebody who religion is a very meaningful part of who they are and their identity, this can be a very important part of that as well. And then finally, there's this idea of the sober curious movement. This isn't a movement or an organization, but it's definitely gotten some traction, especially with the younger generation now, of the awareness of the harms of alcohol, the risks of alcohol use and alcohol ingestion. And there's a lot of movement in this area to provide alcohol alternatives. There's a very, very big social media presence, whether or not you hear dry Januaries or sober Octobers. They call these TAACs, or temporary abstinence from alcohol challenges. There was one study that I could find based on about 1,700 adults who were in their mid-20s. 10% have at least heard of it. 7% had participated in one in the last year. And interestingly enough, if an individual participated in an abstinence challenge, even after the challenge was over, about half of them were using less alcohol, and 15% of the individuals who actually participated in this challenge stopped using alcohol altogether. So, there's a real effect to these movements. Again, it's this whole idea of peer support, being a part of a community, trying something together with somebody else, this idea of challenging oneself. So it's an interesting movement to see. Not only that, but there's also, there's entire menus, there are entire bars that now dedicate menus to what they call mocktails, right, which are fun drinks because, 10 or 15 years ago, if you were not drinking alcohol at a bar, you were having a Diet Coke or you were having a club soda, but now there's all sorts of stuff and mixtures and things that you can have they're fun, they're unique, they have a unique taste to them, and it allows you to kind of participate in this social atmosphere of a bar by having something fun in your hands without actually ingesting alcohol. So it's been very interesting to see, and I'm interested to see where it's going to go over the next several years. So as we finish up part 2 of our talk, a summation of our entire 2 lectures today is one of the 4 take-homes I want you to take is that addiction is a medical disease. It is a chronic medical disease, which means we need to deal with it in a chronic medical disease model, but that it's treatable. There are known interventions that we can offer, both pharmacologic and psychosocial, that we know improve outcomes. And so that's probably one of the best parts about this definition of addiction, and one of the things I want you to be most aware of is that there are interventions that we can offer to improve outcomes. Alcohol use disorder is very prevalent. Almost 30% of individuals are going to meet criteria for an alcohol use disorder at some point in their life. So it is inevitable that you will encounter patients with active alcohol use disorder in your clinical practice. There are 3 FDA-approved medications with very good proven efficacy, and several off-label medications with at least some proven efficacy to help individuals achieve either risk reduction or abstinence. And there are many options for patients to find peer support. It doesn't have to be a religious organization. It doesn't have to be a 12-step organization. There are many different things and communities that individuals might find that they feel like they belong to support their efforts in recovery.
Thank you for listening to part 2 of this virtual training on alcohol use. When is it a problem and what can be done? If you like this content, check out more episodes of the Governor's Institute's Addiction Medicine podcast. You can find it on all pod platforms. And for more training opportunities, including the Governor's Institute's spring, summer, and fall conferences, go to addiction-medicine.org. Thanks again and have a great day.